Hey everyone, welcome back to Cardiology 305. Today we're diving into one of the coolest and most underappreciated intersections in medicine, hepatic manifestation of cardiac disease, with special focus on congestive hepatopathy and ischemic hepatitis. I'm Dr. Fernandez, and this is strictly for educational purpose. If your liver and heart are teaming up in ways they shouldn't, you're in the right place. Stick around, this could literally save lives, and I promise some mind blowing aha moments. Hit that like button if you're ready to level up your medical knowledge. By the end of this video, you'll be able to understand the bidirectional dance between heart and liver. They affect each other more than you think. Spot the key features of congestive hepatopathy and that dramatic shock liver. Get familiar with Fontan-associated liver disease in congenital heart patients. Recognize cirrhotic cardiomyopathy and those sneaky lung complications in liver disease. See why MASLD, that fatty liver everyone's talking about, is major cardiovascular threat. And master the basics of diagnosis, meds, and transplant decision. Sounds good? Let's jump in. And don't forget to comment which topic excites you the most. Hepatic vulnerability to cardiac disease. First, why does the liver care so much about the heart? Simple. About 70% of the liver's blood supply comes from the portal veins, which is basically low oxygen, nutrient rich blood from the gut. It's like the liver is running on decaf most of the time. The centrilobular hepatocytes in Zone 3 are at the end very low oxygen line. They're the first to suffer when blood flow or pressure goes wrong. Think of the liver as a sensitive roommate who complains loudly when the heart isn't pumping properly. This vulnerability sets the stage for everything we're about to cover. Congestive hepatopathy, pathophysiology. Congestive hepatopathy is what happens when the right side of the heart is struggling and backs up pressure into the liver, like a traffic jam in the hepatic veins. Common culprits: right heart failure, bad tricuspid regurgitation, restricted cardiomyopathies, or advanced biventricular failure. The result? Passive congestion, sinusoidal dilatation, hepatic atrophy, and over time fibrosis that can lead to cardiac cirrhosis. It's not true cirrhosis from alcohol or virus, but the liver still gets scarred from chronic backup. Imagine your liver slowly turning into a congested sponge. Not fun. Congestive hepatopathy, labs and clinical feature. Lab-wise, you see cholestatic pattern, elevated bilirubin, GGT, and ALP. Synthetic functions can suffer, prolonged PT-INR. Transaminases are usually only mildly up unless ischemia piles on. Clinically, affects 15 to 65 of severe heart failure patients, even higher in those heading for LVADs. Many are asymptomatic at first, but you might see jaundice, ascites, or just fatigue. It closely tracks right ventricular dysfunction. When your heart failure patient has a weird liver test, think congestion first. Congestive hepatopathy imaging findings. On imaging, you'll see the letter IVC and hepatic veins, the classic nutmeg liver appearance on CT or MRI. With that model, heterogeneous enhancement. Doppler shows loss of the normal triphasic waveform in the hepatic veins. It becomes flat or reverse. Elastography can measure stiffness, but beware. Active congestion can falsely elevate the numbers, like measuring a water balloon instead of solid tissue. This is where radiologists become your best friends in diagnosis. Ischemic hepatitis or chalk liver. Now that Now, for the dramatic one, ischemic hepatitis, also called chalk liver or hypoxic hepatitis. This is an acute insult, sudden drop in liver blood flow or oxygen delivery, usually from cardiogenic shock or bad heart failure flare. The hallmark? Skyrocketing aminotransferase, often greater than 20 times upper limit, peaking in just 1 to 3 days, with huge LDH jumps. ALT to LDH ratio less than 1.5 points to heart origin. It looks scary on labs, but the liver usually recovers if you fix the heart. Prognosis is all about the underlying cardiac crisis, not the liver damage itself. Biopsy? Almost never needed. Think of it as the liver hanging a massive panic attack from lack of oxygen, then calming down once the blood flow returns. Fontan-associated liver diseases, FALD. Next up, a special population, kids and adults with single ventricle congenital heart disease who have had the Fontan procedure. In Fontan circulation, systemic venous blood flow passively straight into the lungs. No pumping, ventricles in between. It's a brilliant surgery, but over years it caused chronic high pressure in the veins, and that backs up into the liver. FALD is basically universal. Liver changes start within 5 years, and everyone has some fibrosis on biopsy. Severity worsens with time. Bridging fibrosis is about 35% with the first decade, and severe fibrosis in up to 68% in some groups, plus increased risk of liver tumors. This is why lifelong surveillance is critical for these patients. Surveillance is key. Start baseline liver labs 5 years after Fontan, then MRI, preferred every 3 to 5 years. In advanced disease or cirrhosis develop, switch to abdominal imaging every 6 months, plus hepatology team for hepatocellular cancer screening, HCC screening. In select cases, combined heart liver transplant is becoming more common. These patients need a village of specialists. Cardiac complications of chronic liver disease. Time to flip the script. Now the liver affecting the heart. We'll cover three big ones: cirrhotic cardiomyopathy, portopulmonary hypertension, and hepatopulmonary syndrome. The heart-liver relationship goes both ways. It is a true partnership, sometimes a dysfunctional one. Cirrhotic cardiomyopathy. Cirrhotic cardiomyopathy is hidden heart dysfunction in cirrhosis patients without obvious primary heart disease. Features: poor response to stress, diastolic dysfunction, often the first sign, and electrical issues like QTc prolongation in about 50% of patients. Prevalence range 26 to 81%. The 2020 consortium criteria focus on global longitudinal strain and diastolic parameter is sneaky. Patients look fine at rest but crash under stress. Cirrhotic cardiomyopathy pathophysiology and implications. Mechanism include messed up beta-adrenergic signaling, stiff cardiomyocyte membranes, ion channel problems, and a storm of inflammatory cytokines like TNF alpha, IL-6, nitric oxide, and endocannabinoids. For transplant teams, subclinical cirrhotic cardiomyopathy raises post-liver transplant heart failure risks, though it can partially reverse over years. Timing and monitoring matters a lot. Now, portopulmonary hypertension and hepatopulmonary syndrome. Two pulmonary complications you must know. Portopulmonary hypertension affects 2 to 6% of portal hypertension patients. Pulmonary vessels constrict, remodel, and thrombose, raising pressure. Severe cases can block liver transplant. Hepatopulmonary syndrome, the opposite problem: liver disease plus low oxygen plus dilated lung vessels. Classic trial: patients get platypnea and orthodoxia, worse breathing upright, Diagnosed with bowel echoes, prognosis can be tough. MASLD as a dependent cardiovascular risk factor. Metabolic dysfunction associated steatohepatic liver disease, formerly NAFLD, hits 30 to 40% of adults worldwide, even higher with diabetes or obesity. Here's the shocker: cardiovascular disease is the number one cause of death of these patients, beating liver problems. It raises cardiovascular events risk by about 1.5 times independently, up to 2.5 with advanced fibrosis. Shared culprits: insulin resistance, inflammation, oxidative stress, and bad lipids. This is why cardiologists and hepatologists need to talk more. Metabolic dysfunction associated steatotic liver disease, MASLD. Guidelines are clear. Is recommend 5-4 first, then elastography in at-risk patients. ADA 2026 says screen anyone with prediabetes, type 2 diabetes, obesity, or cardiometabolic risk. Goal is catching at risk MASH with significant fibrosis early. Early intervention can change trajectories. Practical approach started with labs. BNP is goal, ECG, and echo with strains. For liver transplant candidates, re-stratify coronary disease screening. In cardiac patients with liver issues, full LFT panel, CBC, non-invasive fibrosis tool, 5-4, elastography, and MELD scores. Multidisciplinary teamwork wins here. Anticoagulation in cirrhosis with cardiac indications. Tricky topic: blood thinners in cirrhosis with atrial fibrillation or clots. Generally okay in child hooks AB with no major bleeding risks. Dogs often prefer apixaban, frequently comes out on top for safety. Rivaroxaban avoided in child V, and all dogs usually out in child C. Use low molecular weight heparin instead. Thrombocytopenia below 50K is a red flag, always individualized. Drug safety consideration: amiodarone can hurt the liver. Monitor LFT every 6 months and stop if enzymes climb too high. Statins are actually safe and often beneficial in compensated liver disease. Avoid dronedarone in advanced disease. Pioglitazone, great for liver but bad for heart failure due to fluid retention. Alcohol-related consideration: quick but important. Heavy alcohol, greater than 80 to 90 grams per day for more than 5 years, can cause alcoholic cardiomyopathy, dilated heart muscle. The single best treatment: total abstinence. Many patients see partial or full recovery of heart function. Continue drinking, high mortality. Liver and heart both hate chronic heavy drinking. Double whammy. Transplantation and surveillance. For combined failure, assess if liver disease reverses with heart optimization. Combined heart-liver transplant is an option in selected cases. Post-transplant, frequent cardiac checks, annual cardiology visits. Watch lipids and diabetes aggressively. Hydrophilic statins are often safest with immunosuppressants. To wrap up, heart and liver are intimately connected in both directions. Congestive hepatopathy, chalk liver, FALD, cirrhotic cardiomyopathy, and MASH-related cardiovascular risk all demand team care. The field is evolving fast with better tools and therapies. Multidisciplinary collaboration is the future. Thanks for watching. Drop a comment. Have you seen any of this in practice? Which slide surprised you the most? Full references are in the description below, including the HA statement and guidelines. Always check latest evidence. That is for today. If you learned something, smash like, subscribe, and turn on notifications. Share with a colleague or med student friends.